everyone. This is David Bronstein of MCOL and Health Web Summit, and I'd like to welcome you to our webinar event, Predicting Medication Adherence, Implications for Readmissions and Overall Outcomes. Our speakers today are Brian Wolf, MD, Senior Medical Director, Health Management Integration Groups.
Well, thank you very much, David. By way of introduction, I'm the Senior Medical Director at Blue Cross Blue Shield of Rhode Island, and amongst the various things that I do here is I have a role in health analytics, medical management, and contracting and their confluence. And one of the issues that has been of utmost importance to us is how do we improve the care of our membership at a population health level, and how do we remove some of the excessive costs in healthcare and hopefully accomplish both. And from that perspective, we have looked at the manner in which we conduct ourselves from the perspective of how do we save dollars. And at the end of the day, when you analyze healthcare dollars, the most important single contributor are individual days in the hospital. And so if you have some way of improving the care of patients, and they are healthier and have less days in the hospital and shorter days in the hospital and fewer readmissions for their various disease states, you have people who have a better quality of life, a healthier index through measurement, and you've taken some of the costs out of healthcare. So we've struggled for a long time with the concept of what can be done in order to reduce the rate of readmissions to hospitals. And we struggle with that and have done so for a number of years, even before Medicare became somewhat obsessed with this. So we've looked at the usual gamut of issues that seem to be intuitively important. We've developed comprehensive, exhaustive transition of care analyses. And if we start with slide 4, which I think is a reasonable starting point for any discussion of readmissions, and that is, whereas a primary admission can be viewed as an isolated event in the natural history of an individual's disease states, readmissions tend to be reflective, in many instances, of either incomplete care or inadequate care of a prior admission. And though there are instances where readmissions are entirely unrelated, so I like to cite the example of somebody who has successful surgery for, let's say, valvular heart disease, is doing well and is unfortunately in a motor vehicle accident several weeks after their discharge from the hospital. That is an act of fate that there is no possible control on, and those are not the readmissions that I focus on. Though the Centers for Medicare and Medicaid have been so prescriptive in the view of readmissions that we're essentially looking at all causes of readmission. But recognizing that we can affect what we can and those that we cannot, it's a moot issue, except that CMS recognizes that coming back into the hospital after an admission is a significant event and one that should be minimized in order to provide the best possible care for their beneficiaries. In pursuit of that, and particularly with concerns about the penalties associated with unacceptably high readmission rates, folks in hospital settings, practitioners in risk arrangements with hospitals, and payers have been somewhat obsessive, which I think is a mild way of addressing this, in terms of, so what do you do about readmissions? How do you get a handle on this, and how do you reframe the conduct of care so that avoidable readmissions are indeed avoided? And at a state level in Rhode Island, and I should step back and say Rhode Island is a small geographic place that is akin to a city-state, and at Blue Cross, we're in an unusual circumstance where we are responsible from a payer perspective for about 2/3 of the population that have coverage. So that we have pretty good data, and it's a relatively closed system. And so we collaborate and across hospital lines and with the other payers and with the state, and we developed a approach to looking at readmissions, and we called it our Transition of Care Program, not terribly novel, and we stipulated the usual sort of scenarios that I like to think of as the principles of good etiquette in healthcare. Primary care doctors are notified by the hospital that their patients have been admitted. Primary care doctors notify in turn the hospital when they're sending a patient over. That there's a good flow of information from the hospital to the appropriate clinicians who are going to care for patients in the community. That the patients are educated, that they have instructions, that they have contacts, that medical reconciliation has been conducted prior to discharge. Ideally, it's conducted prior to admission. That there are appropriate appointments made up, and that the usual events that we would think would be part and parcel of effective collaborative care occur. And we've been doing this now for in excess of 3 years, and it is difficult to say that there is any element of this that in and of itself is the critical component, and it creates a tremendous amount of paperwork, and I think it's valuable, but it is very much process-driven, and there are lots of potential pitfalls. And one of the pitfalls is that from an engineering perspective, good process doesn't necessarily lead to good results from the design perspective, and that remarkably, patients don't always do what you would like them to do, so that the greatest single difficulty with our Transition of Care Program is that most of our patients seem reluctant to accept follow-up appointments scheduled by the folks in the hospital with their community doctors. And there are lots of reasons, many of which are quite legitimate. But on the other hand, a lot of the follow-up visits maybe are done reflexively by the hospital and don't make a whole lot of sense. So we stew about these things in the health analytic area, and we spend a lot of time trying to figure out, so really what does make sense? And in a session where we were kicking this around, the notion came up with, well, what is the biggest single problem that we encounter with our patients leaving the hospital and then returning? We know that the common disease entities that are most often associated with return to the hospital unexpectedly have to do with pulmonary failure issues, cardiac failure issues, and infectious processes, particularly associated with surgeries. So we started looking at our data, of which we have a lot. And if we move to slide 6, what we found was something that was quite remarkable. When we looked at our Medicare population and we mapped out when they filled their prescriptions and what the likelihood was of them being readmitted, we saw that if they actually filled their prescription the day that they were discharged from the hospital, not surprisingly, they had the medications on hand, took them, and didn't come back to the hospital very often. If they waited a number of days, the likelihood that they would be readmitted increased. And if they waited a long period of time, it increased dramatically. And we looked at the data across various diseases, and it didn't matter what the disease was for the admission. We looked over time, and what we noticed that the general contour of the curves were the same no matter which year we looked at. But what we did notice was that if we looked at data from 10 and prior and then compared it to 11, that in 11 we did much better across the board. And we would like to think that since 10 was the hallmark year for the vigorous institution across all hospitals of our transition of care program, that the shift of the curve from 10 to 11 is the consequence of what we did with our transition of care program. So we said, okay, so if this is true for Medicare, and Medicare is where everybody becomes apoplectic, how about commercial? So if we look at slide 7, we see a similar phenomenon. Slightly tighter curves, but nonetheless, the same shape, the same correlation with early fill versus late fill and increasing rates of readmission, and a slight improvement of 11 over 10 and 9, reflective of incorporation of our transition of care program.